Thank you very much, Gaurav, for the nice introduction. I would like to share with you some pearls on using the ring in intraoperative floppy iris syndrome, because there are some differences that you may face and difficulties that you may face as opposed to the regular small pupil cases. We all know that intraoperative floppy iris syndrome is the condition that is characterized by triad of symptoms that was nicely described by Chang and Campbell a little bit more than 10 years ago. And these three signs is a floppy iris that billows and billows in response to normal irrigating currents. The iris that is coming down during the procedure, and the iris that is prolapsing through the side port and main incisions. And this is a clinical example of this condition. As you can see here, as soon as viscoelastic will leave the anterior chamber through the side port, as you can see right now, so immediately the iris starts billowing and prolapsing because nothing holds the iris in place right now, and the procedure become challenging because the pupil started to constrict, and of course in these situations iris trauma is very likely, and you probably need some additional manipulations and devices. As you can see here, I decided to go on with the Malyugin ring, but in these particular cases, the pupil is not very small. Actually, it's large. So if you will be using a smaller ring, it will be too small for this size of pupil. So first of all, think about using the bigger one, which is 7 millimeter, because smaller one will probably, in some cases, not fit into this particular case in this particular patient. At the end, the surgery was okay, although we can see some pigment dispersion in this area, and there is no pigment on the iris margin, but this will not cause any significant issues postoperatively. We know that the IFI syndrome is characterized by thinning of the muscle dilator, dilating the pupil, and that was nicely shown on cadaver studies. But in most of the cases, possible pupil issues can be anticipated when you talk to the patient preoperatively. You're taking his medical history and medication history. And also, if you try to dilate his pupil, and you may see that pupil is not dilating well, so definitely in these particular cases you may anticipate that the pupil will not be optimal during the surgical procedure. And of course, surgical planning, meaning that you may have specific devices to be at hand during the procedure and should be ready. So with regard to the standard technique of the Malyugin ring use, like in this particular patient, you see that the ring is injected with the help of the special injection device, and I like to position tip of the device very close to the iris margin, and both lateral scrolls usually engage with the iris as soon as I'm injecting the ring. And what will be necessary is to just reposition the last scroll, which is proximal to the incision. Sometimes you need to reposition the device and then use your manipulator or hook and catch the iris margin, like shown on this video. And to remove the ring, it's also quite straightforward. Usually I disengage the distal scroll first, followed by the proximal scroll, and I usually do not disengage lateral scrolls because they automatically goes inside the injector tube during the procedure. So the scroll is lifted a little bit above the iris plane. I position the footplate of the injector and catch the ring with the injector hook, and then retract the ring back into the injector. And don't forget to press on both lateral scrolls, so it will be helping you to place the ring completely inside the injector tube. So when you're operating under topical, definitely you would like to inject lidocaine or anesthetic into the anterior chamber to prevent any sensation. You don't want to overfill your anterior chamber with viscoelastic, because with this maneuver you are pressing your iris towards the anterior lens surface. It's good to position the injector tip very close to the iris margin, and this helps you to control the ring, and slowly withdraw the inserter while expelling the ring. Of course, we should remember the golden rule that in intraoperative floppy iris syndrome, you should not stretch the pupil, and this maneuver is contraindicated. What about implantation after capsulorhexis? This is more challenging because what you can have is that you can catch capsulorhexis edge unintentionally, and this may lead to losing of the integrity of the capsule. So as you can see here, I'm doing a hydrodissection, and during this hydrodissection I realized that the pupil is coming down, and I decided to use the ring in order to expand the pupil, because I was anticipating that if it starts coming down during the hydrodissection, so it will be going further and further, and the constriction will happen during the procedure. So I'm injecting the ring in a quite irregular manner that I was just describing you. I'm trying to catch both lateral scrolls. Sometimes you need to go back and forth in order to better control the position of the lateral scrolls, and then releasing the distal scroll, as you can see here. And I will use ring manipulator to place the last scroll. And then what is very important is to check whether you catch capsulorhexis or not. And this check, you are trying to displace the ring to the left or to the right, and if you can see that the ring is not mobile, it's not moving. So then that gives you the idea that probably it catches the capsule at this point. And you identifying this point, you are being able to disengage the scroll and then proceed with the next steps. And then procedure became routine, and I'm now removing the device from the anterior chamber, utilizing the neo injector. As you see, it's having a little bit thinner hook that catches the scroll. And then I'm removing the ring from the eye. Sometimes you can see some depigmentation coming from the posterior surface of the iris, but usually it is easy to aspirate with while removing viscoelastic, and it does not cause any problems. So there is another option of implanting the ring, is to utilize the wound assistant implantation, because when I'm using incisions that are 1.8 millimeter in width, it's not possible for the injector to go through the incision. So wound assisted implantation, like we are using in some types of IOLs, is quite helpful. Unfortunately, when using wound assistant implantation, you're not being able to place all three scrolls and engage with the iris. So usually the ring lays on top of the iris, and then you have to manually engage all the scrolls one by one. I do like to engage contralateral scrolls because with this you stabilize the ring, and it's much easier then to engage the other two pair of scrolls while the ring stays in place. Again, in this case, the ring is implanted after capsulorhexis. That's why you have to watch very carefully and to control how the ring stays in place and whether or not you are catching the anterior capsule. And again, displacing to the left and to the right will help you to identify whether or not the capsule is catched. And I think that I catch the distal scroll, as you can see here. And so what I have to do now is to come back with the manipulator, retract the ring, lift it a little bit back above the plane of the anterior surface of the iris, and then position it back. And now, as shown here, the ring is not catching the capsule, and the procedure will be more or less routine. So don't forget, when you are implanting the ring after capsulorhexis, check the mobility of the device and then decide whether or not you will be able to complete the procedure. At the end of the case, removal of the device is quite easy and does not have any technical difficulties. Again, I'm not being able to use the injector because I'm not being able to insert the injector through the small incision. That's why I will be using the hook. I will hook the proximal scroll, catch it, and remove the device from the eye. But you have to be quite careful with this maneuver because when you're removing it, there is a chance that your lateral scroll will catch the internal lip of the tunnel. That's why going under the ring with the spatula will help you to avoid this situation and remove the ring safely. And I thank you for your attention.